Good day to our respected audience, and special thanks to Bangladesh Oncology Club for giving us this platform. We are from the M-Health Lab of the Department of Biomedical Engineering in BUET, Bangladesh University of Engineering and Technology. To give an introduction, at the M-Health Lab, we work with biomedical signal processing and machine learning algorithm for remote healthcare monitoring. We also construct cost-effective devices to address the unique healthcare challenges of developing countries like Bangladesh. Today, we are presenting our research, Colposense, Development and Evaluation of an Artificial Intelligence Framework for Cervical Cancer Detection from Colposcopic Images. The principal investigator of the research is Dr. Taufiq Hasan, who is a professor at the Biomedical Department in the BUET. But unfortunately, his flight from Nepal was delayed, so we are giving the presentation on his behalf. I am Asfina Hasan, and this is Ryan Kobir. We are both graduates from BUET, majoring in biomedical engineering, and currently work under the supervision of Taufiq Hasan. Let us also introduce our co-principal investigator, Dr. Nasrin Ara Jaman, who is a professor currently working in the Ibn Sina Medical College Hospital, and our clinical collaborator, Dr. Aklima Zakaria Zinan, who is an assistant professor currently working in Bangladesh Medical College Hospital. Now, research works with cervical cancer. As this is a gyne-oncology session, we all know that this is a very common cancer and claims 7 women out of 10,000 women in Bangladesh. The most common screening method for cervical cancer is colposcopy, where the physician visually examines the cervix, vagina, and vulva for abnormal tissues. Now, our research motivation is to mainly build a decision support tool by AI for giving a colposcopy diagnosis. Now, what is a decision support tool? Decision support tool is a software which is like a trained assistant. The tool trains on 1,000 of medical data and can give a provisional diagnosis. In this research, the tool will be trained with colposcopy images and their corresponding reports so that when a new image is given, the tool can give a provisional diagnosis. Now, our particular aim of the research is remote areas where there is a lack of expert and trained personnel. We believe that by providing technological aids in such areas, the cervical cancer screening accessibility can be increased. Now, for our objectives of our research, as we said, in remote areas, this AI can work as a training tool and also as a guide. But for places where there are already expert physicians, the AI can work to reduce tedious work operational load. Now, there is a popular conception that AI may replace human beings, but that is practically not possible, especially in the medical field, where doctors have to make split-second decisions and there is a variety of medical data. So there are some things that only physicians can do. In this case, AI can work to reduce operational stress and save time of physicians by providing prompts throughout their report writing. The decision support tools can also help standardize clinical reports across various institutions. And in case of complex or rare cases, the decision support tool can also provide a data-driven second opinion or insights. Now, to develop our AI model, we focused on 2 areas of colposcopy. Firstly, the transformation zone, and secondly, the sweet score, which is a WHO recommended scoring criteria for colposcopy. It evaluates the colposcopy on 5 characteristics, namely the acetoide uptake, the margins and surface, vessels, lesion size, and iodine staining. Now, to develop our model, we used 3 datasets. The first 2 datasets are international and publicly available datasets. The third dataset is a dataset we collected from a local health facility. The first international dataset, which is the Intel and mobile ODT dataset, it has 8,206 images of colposcopy. The only available annotation of this dataset is the transformation zone type. The dataset was contaminated with motion blur and focus blur, and it also had very low resolution. There was another problem that the dataset contained class imbalance. Like the type 2 transformation zone images were in abundance, while type 1 and type 3 were less. Now, the second dataset is the WHO dataset, WHO made it publicly available with 913 images of 200 patient cases. In this dataset, we had the transformation zone type along with a detailed breakdown of the sweet scores. However, this dataset also showed imbalance, like there was an abundance of type 1 transformation zone images, and also the sweet score was not available for all the images. Lastly, to make our research impactful in the context of Bangladesh, we also collected a data set from the Ibn Sina Medical College Hospital in collaboration with our co-principal investigator. Initially, we constructed an ethical protocol which was approved by the ethical committee of Ibn Sina, and then we collected the data. Our target sample size was 500. We managed to get 444 patient cases, among which we could use 214 reports because there was fully detailed transformation zone and sweet score information included in those images. However, as we have seen, most medical data shows imbalance. So in this data set, there was also an imbalance, like there was an abundance of type 1 transformation zone and an abundance of 0 and 1 sweet score, which means that mostly normal patients usually go into this health care institution. Now I will give the floor to Ryan Kobir to discuss about the materials and methods and results of our research. Thank you.
Thank you, Asfina, for the introduction. I will dive into more technical details of the project. So I'm starting from the development of an AI model. So here is an overview of how an AI model works. Firstly, we need data. Generally, we need huge amount of data to train an AI model. Then developing an AI model includes collecting different mathematical and statistical operations, which we apply on the images like convolution or other types of filterings. This set of operations make up the AI model. The AI model is used to extract the features of the images. In our case, we extract the features of lesion borders, color, texture of the cervix. These features are then used to train the model. We usually use 60% of our data to train the model. Then other 20% of data is used to validate the model. We keep the rest 20% to generate the test predictions and generate the performance metrics. So the next step is decision making. We generate predictions on the rest 20% data. In this case, the model doesn't see the data labels, so we don't tell the model which image is type 1 or type 2. So the trained model predicts it. Then we score it against the actual levels and we generate the performance matrix, which is the model evaluation. So in our framework, we have two parts. The first one is the transformation zone classification. This is the framework for transformation zone classification. At first, we have a classification model. As I have said before, this is the artificial intelligence model, which is a set of mathematical operations. And there is another part in this model, which is called artificial neural network. It mimics the human brain workflow, and it is built mimicking the human brain structure and how the neurons are connected inside the human brain. We have trained this classification model with the larger data set we have in our hand, that is from Intel and mobile ODT. Then as the Intel data set is mostly developed in Africa, we cannot apply this model directly into the data set of Bangladesh. So we have utilized the WHO data set to fine tune the model. It basically changes the model weights to modify it for generating a test inference and improve the model performance. We have generated the test inference on the local data set we have developed. So we need to pre-process the images before we input them into our model. So different kind of pre-processing steps are there to address mainly the class imbalance of data. For example, we cannot input 900 images of type 1 and 50 images of type 2. The model would be automatically biased towards type 1. So we tell the model to see the 900 images once and the 50 images of type 2 18 times. So ultimately the model understands that there are 900 images for both types. So the classification performance improves in this way. Another technique is augmentation. We flip the images, rotate the images, and then input it to the model. It works in two ways. One is it increases the number of data which is beneficial for AI models. Another is it can detect rotated or tilted images in case the colposcopy is not clear. Here is the results for our transformation zone classification. We can see our proposed colposense model can already perform statistically better than other baseline models. These VZZ 16, ResNet 50, these are the baseline models. The state-of-the-art models for image classification can be applied for any image, but we have utilized for colposcopy images. The next part of this project is sweet score prediction, which is very important for colposcopic assessment. For sweet score prediction, we have faced the first big obstacle of our research, that sweet scores are assigned to each image or each characteristic, like score 0, 1, or 2. But for score 2, we had very little number of images here. For example, margin score 2 image were absent in our data set. So to tackle this scenario, we have combined the score 1 and score 2 images and given it score 1. Then we have classified between 0 and 1 for each of the 5 characteristics. In this part of the model, it gets a little complicated. We have 5 classifiers here. Each classifier classifies for each characteristic. For example, the acetouptake classifier scores between 0 and 1 for aceto-white uptake. Similarly, for margins vessels, we have 5 different classifiers which give a score, which generate a score. Then we sum up the score to generate the ultimate sweet score. In this workflow, we have added step, which is removing the specular reflection from the images. We know that multiple images of colposcopy have specular reflections, so the aceto-white uptake cannot be visible clearly. It is already white and light interferes with the tissue. So we have removed the specular reflection from the images. Then we have used the previously discussed pre-processing steps. Then we have used some simplified classifiers here, but there are 5 different classifiers which combines different baseline classifiers. Then there is dense layer, which mimics the brain structure of human. It gives us the prediction of 0 and 1. Here is the result. In this case, we have calculated the error. We can see the final absolute error is 1.67. So the model can predict the score within the range of 1.67 of the actual score. This error is high because we don't have samples for score 2, and we have calculated that score 2 would be score 1 in our analysis. So when we have more samples for score 2 and the dataset becomes more balanced, we would be able to improve this error. We have some observations from this research. First one is that using multiple inputs for one characteristics improves the overall score. For example, here for margins, we have used 2 inputs that are acetic acid images and normal saline images. Then we have used 4 inputs. It improved the result. Another observation is if we can focus on the region of interest. If we focus on the region of interest, it improves the model performance. So here are the limitations of our research, which is mostly for data set. We have utilized small data sets which caused overfitting. Overfitting means the AI remembers all the samples and it tries to predict based on its memory other than predicting based on its features. We had class imbalance in almost all the data sets, which is detrimental to the AI model performance. And we also need variability in our data set. For example, we have Intel data set which is built on Africa. So if we have data from Africa, Europe, Indian subcontinent, we can develop a more comprehensive data set. In our future work, we would like to address we would like to utilize generative AI, which means we can synthesize samples using AI. And the most important part should be incorporating this algorithm to a device, because user feedback is very important in this kind of research. Thank you for your patience.